Björn Berg. I'm a radiologist, professor for medical information systems, professor at Heidelberg University, where I'm also CIO and CTO, responsible for all IT and technology and medical equipment. So this morning's session is going to focus on essentials of corporate and IT strategy in hospitals. So obviously we have a certain focus, and we have an interesting panel here this morning. The first one to give us the first presentation is Mr. Jaeger. He's the CEO, so basically a general manager, not really solely focused on IT. Very broad tasks, many more tasks, if I get it right, than IT on the Ameos group, and he's going to present us something on the hospital internal aspects. Are you so far ready, or am I pressing you? No. War doch richtig jetzt. Okay, while he's connecting, we can already present shortly the next speakers also. The following speaker is going to be Mr. Costa, who's sitting right to me. This is the CIO of the St. Luke's Hospital. He's going to speak about business alignment and hospital in Belgium. He will be followed by Alexander, who's going to present and speak on enterprise communication in his state in Austria, which he's going to present. And finally, Willi Steyer, which you all know, is going to present on communication also. So then we can start with the first presentation on, you can see, right, essentials of corporate strategy in hospitals.
Good morning, everybody. My task will be to introduce you to corporate strategy and hospital strategy and find the way over to IT strategy that will be then taken up by the following speakers. First of all, what is Ameos all about, so that we understand from which background I'm speaking. Ameos is a hospital company that runs 36 hospitals in the German-speaking countries, and out of those 36 hospitals, 33 hospitals have been former public hospitals. So in the last 10 years since we exist, we have been growing very fast. We do not only run hospitals, we are actually in 4 business areas, that 2 of which are hospital areas, so that includes medical hospitals, in which we run hospitals with at least 400 beds, so medium-sized hospitals. The second business field is psychiatric hospitals. Here we are actually market leader in Germany, treating by far the most psychiatric patients in the country, especially in the north of Germany, where we have brought up more or less all the former public, in 4 states, we have brought up all the formerly public psychiatric state hospitals. And last but not least, the other business lines are Ameos nursing homes, and Ameos integration, which is stationary support for the disabled primarily. So since there is no voice, I have to replace the voice. This is supposed to show us a little bit the network of hospitals that we are working in. As an example, you see the Amios Clinic in Halberstadt, which I'm going to talk about a little bit in some minutes, a little bit further in some minutes. Here you see old psychiatric hospitals. Now we go back to a somatic hospital. This is a psychiatric hospital. This is nursing, and finally integration. So this is again for business divisions. I guess we go on because it doesn't have we have no voice. As I said, I'm going to talk about a little bit about Amios Clinic in Halberstadt, which we now run for 7 years, and in which we have completed the turnaround. We took over the hospital back in 2004. In those days, we had 733 employees and treated 18,000, a little bit more than 18,000 patients per year. The hospital in those days, in November 2004, was in insolvency. So very often hospitals go bankrupt in November because then they have to pay the double salary because of the 13th month salary, the Christmas salary that is due to be paid end of November also. And since personal costs are dominating in hospitals, this is usually the time when it becomes very critical financially. So, very typical, the development you can see the first 2 years, no big changes. Even the number of employees went down in the first year. That is due to the fact that many good employees, many good physicians, many good nurses leave the hospital in that critical time. They often resign actually before we take over, and then only work for some more months and leave during the first year. The first difference that we were able to make via our strategy to increase the revenue, so we introduced 2 new departments, which was a new department of orthopedics plus a new department of cardiology. The first effects of this you can see in 2006. So the number of cases hasn't gone up yet, but we had again more employees employed. So 2007 you see the number of cases went up, and that development actually went until 2009. Now we are back, or not back actually, we have more employees than we ever had before. We are now at about 800 employees, and the number of cases we have is around 23,000 per year. So what did that mean for investments? You can see that there is quite an amount that we have invested year by year. So between 3 million and 5 million per year, every year since 2004 until recently. What does it mean in terms of profit development? When we took over the hospital, we had a deficit of 4 million euros per year. Same thing again. First year, we didn't make a positive difference. We made firstly a negative difference, so deficit went down to 4.5 million euros. Then 2006 was actually the first year in which we were able to halve the deficits, 2007, we were still in negative numbers. 2008 actually was the first year in which the hospital was profitable again, and that has continued since. So we are between 3 and 5 million euros profit per year since then. So what is the importance of the IT strategy? From our point of view, in an efficient business, we at Amios practice high demands on the integration and on interfaces. Usually we have several hospitals in one so-called Amios region. So for us, it's very important that we integrate these hospitals. The strategy is very often that we don't have every department in every hospital. So we have surgery and internal medicine in every hospital, but all the other disciplines. Amios covers all disciplines. The only thing we don't do is heart transplantations, but everything else we cover. But that is not necessarily covered in every hospital, but it is covered in every region. Regardless of to which hospital the patient comes in the first place, we can make sure that within a 40 kilometers distance, the patient can be served, but in some instances the patient will then be transferred to another hospital in the region. Therefore, our demands on integration and on interfaces are very high. IT systems have a positive effect on the process of communication support. In the clinical area, we use IT systems in order to implement pathways, also in order to document have the patient record documented along the pathway in the IT system. From our point of view, that clearly results in better quality and higher patient satisfaction. A side effect, a positive side effect, is also the fact that the insurance companies or the medical services of the insurance companies are not able to find as many cases in which they can claim inpatient care wasn't possible because the documentation is good, because the documentation goes along pathways. Also, cost savings are there. They usually arise from lower resource consumption because we can implement the pathways and work along the pathways. The effect that one or the other of you might know, which is very common, that a young doctor who is not so experienced, who is a little bit nervous that he might forget something, he is often the one who orders a huge list of lab tests, and by working along the pathway, this problem is reduced. What is the role, finally, and with this I would like to conclude, what is the role of IT at Amios? We can use as considerable synergies as a large group. As I said, because of the clinical systems that we have in place, because of pathway management, we have in place considerable synergies. We can also, in a region, use the same system so that doctors at another site, another hospital, can look into the patient documentation and don't have to go through the full history of the patient again, don't have to ask for the patient records to be sent over via mail, and then they could only start some days later with the treatment. They have access immediately, and this is considerable synergies for us. Our experts work out standards which ensure the experiences that have already been made in other hospitals before can be implemented again in the hospital that they're in. In addition, hospitals in general, I must say, don't take over pathways one-to-one from one hospital to another. As a matter of fact, in each hospital and in each department of the hospital, doctors and nurses sit together and work out the standards for their hospital, but they have the possibility, and they use it frequently, to draw or pull standards that are in place in other hospitals of our group with which there is lots of experience. So, but it is on their decision whether or not they do that, and as a matter of fact, they do it. So it is not like Andreas, via copy and paste, rolls out all the same standards and pathways over all hospitals. It is for each hospital a new decision again to work out the standard in the pathway by using the experience of other hospitals to the degree that it is useful. As a result, the pathways used in the hospitals, in the different hospitals, are very, very similar, but there is individual differences that are due to individual conditions or circumstances at a certain site. Uniform IT landscape and uniform processes support the synergies, so also complex IT projects can be pressed and pushed through in our group. This makes the value contribution of the IT process optimization faster and better. And from our point of view, it is only in a group. And by group, it is not necessarily what I do not necessarily mean Andreas, but I mean a group of hospitals in a region, a network of hospitals in a region. Only in such a group, the full potential of IT can be exploited. However, I might say, this is my personal opinion, but I must also say it is actually a repeating experience. This will only work if the hospitals in the region are under the same governance. So if you have public hospitals under different public authorities, it doesn't work. Even with public hospitals under the same public authority, but with different interests for one or the other reason, it doesn't work. It certainly doesn't work if you have completely different owners. Then we have lots of corporations, lots of contracts that say the hospital should cooperate, but it never happens that one hospital gives up a certain discipline, leads this discipline fully to another hospital, and this other hospital also gives up a discipline which it leaves fully to the first hospital. This doesn't happen because of fear, because everybody thinks there's a danger that he's the loser. So the full potential of the synergies and of the IT systems from our experience can only be exploited if the hospitals in a region, in a regional network are under the same governance. Thank you.
Yeah. Okay, you can stay. Okay, thanks very much for that presentation. I would actually also like to, since we're pretty good in time, to extend the discussion to a certain extent into the auditorium. I would perhaps like to start at the end. You said, of course, it's ideal if you have one organization which governs all the different hospitals. On the other side, that would, to my knowledge, massively conflict with the antitrust issues, which you then always have, because you cannot just simply, dominate the whole region. So let's assume for a second, if that's the case, which I would quite positively assume, you would have usually the situation that you have the hospitals and caretakers in different ownerships, which again then would mean that you would need interoperability between the hospitals as you lined out. To what extent are you identifying deficits today in the processes which you need, and to what extent can you anticipate on an abstract level, if you want, what standards would contribute? Because that's in a way a little what we try to find out where can we help, where is the need. I clearly saw there is a need from the management perspective. Could you help us a little? Where are the deficits today, and where could we help?
First of all, that was your initial remark. Yes, there is antitrust issues. So what we basically do is we take up the care of around 40% in a certain region, but there's always other hospitals, and that is from a general view good, that it is not meant for one provider to exclusively serve a region. Your question was how can standards help, or how can standards be put in place so that the hospitals can benefit from that. As I said, these standards are worked out in our group, hospital by hospital, but as a matter of fact, not every standard is invented from scratch, but when a standard for a certain hospital is developed, then experience from other hospitals are used. So contents of standards in other hospitals are used or taken over, so that in the end the standards are very similar and have strong line of common contents.
Maybe I might, because I know your work and I've already had some presentations from you, to basically avoid a misunderstanding here. You're talking mainly about pathways and clinical standards. So on the other side, we have the IT, the technical standards. So, and which actually leads us to perhaps the 2 points. That's for a second stay inside the hospital. In Germany, we have different, as all know, information systems or possibilities and choices. To what extent did you find your clinical standards, which you defined and which you could basically transfer from between the hospitals, could you bring them into the IT systems? And how, or could you imagine that a standardized architecture with respect to the clinical pathways inside the IT systems could be helpful? Just from your knowledge and your perspective.
Helpful is a little bit, be helpful is not enough. I mean, it's a precondition, okay, so that we can work successfully. Our fate is, when we take over hospitals, we find all kinds of IT systems because they have a history in a different ownership. So when you want to see a carpet of all kinds of systems, welcome to Amios, you can see all kinds of systems. However, what we develop the hospitals to is then very much more heterogeneous in the business portion. We work with SAP, so all hospitals that are with Amios for more than 2 years work with SAP on the business side, and on the clinical side we currently work with 2 systems. One is Aqua and one is Cerner, and both not to the same degree, there is differences, but both from our point of view give us the possibility to implement the clinical pathways. Of course, standardization also in the technical sense must be in place, otherwise we cannot, and we have experienced actually in service in several hospitals, in order to build what we have done to the insurance companies, we need to have interfaces between the clinical system and the business system. Those problems we had to solve at a certain stage, however they are now solved, so we can, in this case, just copy the solutions to other hospitals.
Thank you, Roger. Questions from the audience or comments from the auditorium? Any aspects which you are going to believe in this, please? Could you just perhaps briefly state who you are and how you
Isaac, IHE Australia. Axel, you mentioned that when you talk about hospitals in a region operating potentially to sort of this hospital do orthopedics and that do cardiology, that doesn't work for business reasons. Have you been able to achieve information sharing amongst the hospitals in the region? So at least as if patients move between hospitals, then you have access to the information that they have in terms of a regional health information exchange.
Yes, that's the case. So what we strive for and what we have implemented in the pure AMEOS regions, as we call it, is indeed that patient information can be accessed from all sites, so from all hospitals within a region. However, we have taken over, for example, 4 new hospitals in a region in East Germany back in April 2012, so that's a year ago. And until now, we are not yet in the stage that this is possible, because one hospital has a Siemens system, one hospital has an AQUA system, and the third and the fourth hospital have a solution that has been developed internally that doesn't work at all. So right now we are implementing new IT systems, which is in that case Cerner, and if that is in place, then we are able to share information, or in other words, the doctor from one hospital that the patient has to be referred to from the other hospital can directly look into the patient records. The patient, however, must agree with that. That's obvious.
That actually is an interesting point, because that is always the discussion. Do you really replace the systems, which is risky, cumbersome, expensive to a certain extent, or why don't you connect them? That is perhaps the core elements which we hopefully think we might be able to address via the IHE, XDS, and so on profiles. So what I would like to understand is why is that not possible in reality? And I mean, I know reasons to a certain extent, but I would like to get your evaluation, because obviously for you it seems to be still more cost effective to replace a complete hospital system than to establish a interoperability, which is not good for us, the IHE community, to learn.
Yes, in the example that I just mentioned, the hospital that we took over a year ago, as a matter of fact, we are indeed replacing all systems, but that is due to the fact that all systems need to be replaced pretty soon anyway. So in that case, we are lucky, we are not lucky, because we took over very bad systems, but the lucky side of it is because of the business case of a new investment in IT, the business case pays off anyway at all sites. So therefore we are replacing the IT systems of all these hospitals. In other cases, we also have that. We take over a hospital, and unfortunately, just a year ago, an investment has been made in a completely new system. So in that case, we won't replace it. And what we then have, if in one region there is a hospital with an AQUA clinical system and a Cerner clinical system, what we then have is that we, between departments that have to work closer together, we may now laugh a little bit, but what we have is we have a screen at the other hospital via which you can look into the documentation of the other hospital, but it is separated systems. It is just that in each hospital you have an entrance into the other hospital's system, so to speak. So at least the doctor who treats the patient can look into the patient record of the other hospital, see what treatment has been performed, what diagnosis the patient has, However, he cannot put it over into his system. He will then have to type it in again, to enter it again. But at least the immediate access to the information is there. We are a little bit frustrated, or we have tried to connect the systems, but with that we are completely frustrated, so we don't even try it anymore. We just sit it through until a new investment is to be made anyway, and then we can integrate the systems.
I think it's extremely important statements, and I would really like to give this in the round now. And by the way, you don't have to be intimidated there. We are doing exactly the same stuff. So we are also using remote access functionalities in between systems within the hospital, which are cooperating, simply because we don't have the, well, I wouldn't like to give you the reasons now. But into the auditorium, because he's also industry. What's the problem? Why don't we get? Why do people like us have to do it that way, in the old-fashioned and not really productive way? There's one comment in the back. Please shortly introduce yourself.
Yes, my name is Martin Tiani Spirit. Yesterday I was in the panel discussion. I highly recommend if you introduce a new system, in that case, or that you consider in your requirement definition that this system is not, again, the next silo proprietary system. So I think that's not a real issue today. You can bring it in as a requirement definition. Please do this, consider this. Otherwise, you end up in the same situation as the next proprietary silo element.
What would you ask them to do?
I think the whole audience can help and can bring you some recommendation for RFP requirements, that the interfaces, let's say the IHE interfaces, are still considered.
But I think that is exactly the issue. What is he going to tender? Who tells him exactly? I mean, he can be writing his tender, I want IHE XDS.
We can
this
do that.
Will not, yeah, of course. Well, all the consultants can do that.
Yes.
That's not what we want to do. We don't necessarily want to create additional business.
Yeah.
Not in that domain. Sorry.
No, you're completely right. Another consultant.
So how far are we? How important are? And I'm now pushing a little. How country-associated cookbooks or guidelines?
Yeah.
Are we not leaving the people alone to a certain extent?
Yeah, completely right. I totally agree that they must do this in every country. Switzerland, I think, we have a good e-health initiative, and they're doing it already. What I know is I think we have one representative here.
Yeah, I know that there's we also in Germany.
Yeah,
It's okay that you don't know it yet because you're from Austria. But anyhow, there was more comments. I couldn't see all that. There was one in the exactly and then I saw you three.
Hi, I'm Derek Ritz. One of the things that I want to drill down a little bit into the sharing of information, patient information. And the reason I want to do that is because it's a patient safety and quality of care issue to be able to share patient information, whether they are in your hospital network or not. And I thought the original question was, what if a single patient is getting care in a region, but not all in your network? Do you have a mechanism to share patient information with your competitor hospitals because of patient safety and quality of care issues, not because of efficiencies between your own group?
I hope I understand the question right. I understood the question the way that you said our task should be to integrate hospitals for the patient's benefit, regardless of what the ownership is. Yes. So your request is hospitals should be connected, whether it's Amias hospitals or any hospitals. I must tell you, the truth is that we are not connected to other hospitals, and the truth is that we don't know of any example or of any instance in which this is the case. Very few exceptions in very defined or designated areas like radiology, There are small hospitals that don't have their own X-ray department are connected to a university hospital, teleradiology. In this way, they have a connection. But apart from these very specialized areas or designated uses, hospitals outside or hospitals throughout different ownerships are not at all connected. As a matter of fact, most of our competitors have not even connected their own hospitals in the same region. So with most hospitals in the same region under the same ownership, it happens that the patient is referred from one hospital to the other hospital, same ownership, but the patient there has to be admitted again. Even the personal data have to be entered again. So that is just that is just the reality. So I don't really see a way how we could make sure that we integrate our systems with the hospitals of other ownership. There is no way currently available in the reality.
No, I wouldn't way that you're using.
Yes. I'm sorry?
There's not a way that you're currently using. Actually, I do believe that there are mechanisms that could be employed to do just that.
But for that you would need the commitment, and already the commitment is missing because hospitals in different ownerships mistrust each other. Each hospital thinks that it actually suffers from connecting to each other because information will be pulled away and used by a competitor. So there is this commitment problem. Hospitals in different ownerships are not committed.
But apart from that, I mean, apart from the organization, let's assume for a second, which I think is which is in fact the case, that you would have hospitals in a region that would like to cooperate independently from the ownership. The current situation in Germany is we have 3 major HIS vendors. None of them is really fully XDS compliant. Apart from that, even if they theoretically are connected and are able to display XDS or whatever, I mean, all the other additional profiles which you need to support, it's not really realm. We don't have proper solutions for concept management in Germany. We don't have proper solutions for the OIDs. We don't have proper solutions for the organizations, how to identify if you enter into concept entry stuff. So there's lacking in multiple dimensions. So, and this is what I'm actually currently saying is, like as hospital CIO, I don't know, let's say mid-size or a larger group, is to a certain extent, you cannot really do it. That's the issue. I think it's on the paper, you can do a lot. In reality, we are we're still quite far away from a realistic possibility. I would actually like to continue. But we can perhaps continue discussion a little later, or again, maybe your perception is different where you're living in another country.
Also, hospitals of Vienna. We have been in very much the same situations that the first aim was optimizing internally, even though we are operating several hospitals in the region of Vienna, and the optimization, if you do only internal, is only the first step you have to do. You have to be able to operate and to communicate with other hospitals, because the overall cost for the healthcare system is definitely lower if all the hospitals are connected together. And I don't understand this kind of distrust hospitals have from one to each other. I can't experience it. In Austria, we have other problems, that's definitely true, but not so much of distrust in itself, I think. And we are working together, and we have found one way to try to solve the technical problems of communication and the problems who is bearing the cost and so on has to come partially from the government or from the hospitals, one and each other, talking to each other. because in the end they are solving and reducing their costs overall too. And that should be the main goal for everybody, to reduce the cost, to be able to give the patient more quality in the treatment itself. And I think only looking for their own company and optimizing their own company is nowadays a little bit an ancient strategy for us.
Yes, theoretically I fully agree. What I was saying is just that this is not reality. We haven't found another hospital provider that is willing to fully connect with us. That's such a reality. In Austria, you have, in that respect, ideal conditions. You don't at all have ideal conditions in regard of competition, because in every state in Austria you have an almost monopoly of the state association of hospitals. But from that point of view, it's ideal, because you have same ownership for the vast majority of the hospitals. So I wonder if what you say is right, and I believe it is right. I wonder why is the integration of hospitals for each state within Austria, why is that then not at a more developed stage than it is today?
Okay.
You have ideal conditions, you have same ownership of all hospitals, you could fully integrate them.
Yeah, it's not true. In fact, I'm sitting right here with a representative of another group. They are operated by their own. It's true that lots of the major of the income is spent from a single point in Austria. But in the end, the operating of the hospitals itself, we have a lot of different chains, some single hospitals, different chains of hospitals, and we are right in the process, and we are working together, even if it's not so much the governmental law to do so, but in our own interest too. It's right, we are not in the end point of doing it, but we are on a good way in between things, and we already have connections and communications with other hospitals in a compliant way.
Okay, I would like to actually conclude this. Obviously, there's different worlds. We're in the world of the lucky, we're in the world of the poor. We still need solutions to interoperate.
Just a quick response. I mean, we run 2 hospitals in the state of Steiermark, and actually there's just 3 hospitals that do not belong to the state hospital association. And the state hospitals, they are not connected at all. They work exactly as completely alien hospitals in the way they relate to each other. So when a patient is referred, it is like between any hospitals. There is no advantage at all by the fact that they are under the same ownership and in the same group.
Yeah,
so as long as this isn't solved, I think thinking about connecting hospitals of different ownership is something very ideal. First step should be that the hospitals in the same group should be connected.
I think there's different areas to address. There's one question here.
Just coming back to the idea of this regional exchange, because I'm a family practitioner at GP, and most healthcare actually happens in the community, not in hospitals, perhaps certainly in many countries, maybe not about Germany, but so often the people in the emergency department, for example, would very much appreciate having access to the laboratory tests and recent radiology and information that may have been actually accumulated in the community. So the idea of a regional exchange is more what it's about, including community practitioners, community diagnostics, as well as hospitals. And it's certainly been found in the US, where these community exchanges have been running in some places for over a decade. And, hospitals do find that even though they're fiercely competing, and the US is a very fiercely competitive market, they do actually get benefit. There's over and above what you do to a patient. For example, decrease in emergency department treatment times very significantly more decreased when you actually have sharing of information. Also, the cost of investigations that which is part of repeating CAT scans and pathology. So there are, the idea of the information exchange is not to provide access to all of your information, but to provide access to information that you choose to publish, which might just be as simple as an emergency department summary or some pathology or radiology reports. So it's the IHE profiles for supporting this exist, and accepting that your vendors have not yet fully committed to operating those profiles and supporting them, but it's a direction that you could certainly consider, even if it's a bit left field in current thinking.
Okay. Yeah, thank you. You have addressed, I think, a very important subject, connecting ambulatory care and inpatient care. That is actually something that is a lot value-adding if you have it. We have experience with that in 3 dimensions, I would call it. Doesn't mean that this is what I'm now saying is implemented in all AMIOS regions, but implemented in some, and we are in trial and error with this still. First dimension is the full integration. So AMIOS also runs so-called polyclinica outside the hospital, but those are ambulatory care facilities that are fully owned by us. So same thing again as before. Since they are part of the AMIOS system, they are fully integrated. So the doctor in the polyclinicum can access the patient record in the hospital fully. In many cases, the doctor in the polyclinicum is 1 or 2 days per week also employed in the hospital. In some cases, in other cases, that's not the case. So that is dimension 1. Full integration with our own polyclinica. Dimension number 2 is we have given remote access to certain physicians, certain GPs who are very frequent referrers to our hospitals. With that, we are very restrictive, however. These GPs must be GPs, or we have at least given this remote access at this point in time only to GPs that are very frequent referrers. And the third dimension is an exchange system. It's called Cyberfish. It's a Swiss system in which basically that's communication, but that's on demand. So it works a little bit like Skype, but it's a closed system. So the doctor in his practice can ask to get access to an X-ray, and within an hour or so, whenever somebody sees this request, he can be given access on an individual basis to this individual patient's record, X-ray.
Okay. So last question, and then we'll hopefully proceed. No, it was here in the first. Yeah.
Hello, I'm Winter from the west coast of Sweden. When I'm listening to you, I have a kind of a flashback of what we had 10 years ago, because we were focusing on the IT system. And that is actually one of the major flaws from healthcare. We depend on our vendors, we demand them for suppliers with standards, but in our own cases, in our own practice, we don't do any standards at all. Our region consists of 70 hospitals. We are doing radiology in 29 departments. We are doing the same procedure, but various codings, various whatever. We are not even sure of how to define the patient. So what we did 8 years ago, we defined a regional domain of information model. And from that one, we included that in an RFP. Now we switch the power from the vendor, because they have their information model within their system. And we have that heritage. And it's very hard to do interoperability if you don't define your own information model or what you actually want to do. And now we have done it. So we have done it in radiology, we are doing it in pathology, cardiology, dentistry, and some other screening purposes as well. But the hardest thing is the EPR. And now we have defined that the EPR should not be a system. The EPR is actually a parasite because it doesn't actually invent benefits for us. It's actually harvesting value from other systems or other producing systems. So that could be a good idea to do the information model, because I also think the vendors are looking for that one, to have a good dialogue about what we actually want to do within our process. And by that, and using standard, they could actually help us to provide the best functionality and not system. Thank you.
In terms, maybe, I think the points are very interesting, but perhaps now I would like to proceed to the next presentation, and then we can, if you can retake that up in the next round, that would be great. Well, actually, no. Next round, okay? You can take your question for the next round. So we're now coming to the presentation of Günther, who's going to speak about business alignment.
Once more, good morning, everybody. I will talk about alignment of hospital strategy and IT strategy. First, I would like to introduce myself short. My name is Günther Koska, and I'm CIO of a Belgian hospital, that is at St. Lucas Hospital in Ghent, in Belgium. We are a hospital with 800 beds in the heart of the city. So for the Belgian situation, that's quite a big hospital. We have a lot of small hospitals. And in fact, it's a merger of 3 hospitals. And there I would like to refer to the previous speaker. In fact, we had the same situation with 3 hospitals, and of course, each hospital had different IT systems. And what we did in the 2 mergers was just replacing the systems in the smaller hospitals. But we were in the lucky situations that most of the systems were already outdated, so there was no economic problem about that. And I see that with a lot of colleagues, or a lot of mergers in Belgium, and it's very, very difficult to connect the systems in a proper manner, and very often it's easier to replace the systems. Okay. I said St. Lucas, the 800-bed hospital in the heart of Ghent. What we stand for, we call it reliable care. The Traubal in the Dutch. Reliable care, that means experienced physicians, well-trained staff, and well-maintained equipment in the hospital. So that's our business, and that's what we stand for. And now I would like, from this business strategy, I would like to talk to you about alignment with the IT systems. And I would like to start just with a definition. I put it from Wikipedia. There are a lot of definitions, of course, about alignment. It's just one, and it's good as all the others. Business alignment is a dynamic state in which a business organization, a hospital in our case, is able to use information technology effectively to achieve business objectives. That's what it's about. And what I think it's what's the most important part, it's the dynamic state. So it's not a one-time shot, it's a process. That's important. And it's about how to use IT for the profit of the hospital. That's what it's about. Of course, such a definition is fine as a starting point, but in real life you can't do so very much with it. It's not specific enough. So I would like to show you a model we used to get something we can use in real life. I hope that meets a bit with your expectations. Okay, then we go on. What we are discussing and what we are starting to use in our hospital is the business IT alignment maturity model by Jerry Luftman. It's an American academic, and it was developed, I think, first time it was mentioned in 1999, but in the meantime it was updated several times and further developed. And in fact, it tries to describe what IT business alignment is in reality in a more specific way. And the model is working with 6 criteria. to describe the different parts of alignment, and is using a maturity model with 5 steps. I think you're familiar with such a system of maturity, so I'll just mention it short briefly. But what's very important, that's the 6 criteria, because that makes alignment more specific, more concrete. It describes what it's really about, with what you have to deal in practice. And the criteria, the 6 criteria, they are communication. It's about measurements you use within your hospital. It's about governance. Partnership is, between the business and the IT. Then the scope and architecture of your IT in order to serve the hospital, and the skills, the people you need to do that. I will go a bit more in detail. A very important part, it's about communication, and here it's about understanding between the business and the IT on the one hand, and on the other side also understanding of IT by the business, so that the management of the hospital is aware of what IT can help the hospitals to go further, to go forward. It's also about knowledge sharing, and we see a few other things, but I don't want to go too much in detail. If you want to read the whole, if you want to get the whole description, you can easily find it on the internet, of course, the paper which describes the complete model. Then the second one, it's about measurements. Of course, you have the old-fashioned IT metrics. It's often about bits and bytes, but that's not about alignment. And you have the business metrics, and what you really would need is a combination of some kind of balanced metrics, which are developed from business and IT together in order to describe how you are doing. Then in this part we also find benchmarking, service level agreements, and so on. And now I just would like to give you a very simple example to explain how the model is working in our hospital. For example, we had a problem that patients had an appointment but they didn't show up. So the no-shows, everybody really has that problem. And what we did, what we did then was to send a text message 1 day or 2 days before the appointment to the patient in order to remind them of their appointment. And now when we're talking about measurements, of course, the first things the IT guys did was to do measurement about the text messages sent. Okay, that's okay, but it doesn't say so much about the business really wants. The objective is not to send a lot of text messages, of course. The objective is that the patient is aware of his appointment and he shows up. So what we did in the second stage is to check how many of the patients we reach with the text messages. That's already a next step. It's not only the technical number of messages sent, but it's reaching the patients or not. And then in the next step, we looked at what was the impact on the patients. So just explain. So here is the no-show rate of the patients which didn't receive a text message, which is significantly higher than those who received the text message. So we see, okay, it has impact, it has a positive effect on the business. We have less no-shows in our hospital. And of course, you could go further on in the next step. You could extend the measurements to the patients, ask them feedback, and so further. So that's an easy, a simple example of the different levels of alignment. In the beginning, just pure IT metrics, and then things closer and closer to what the business really wants. Then the next criteria group, it's about governance. And here it's important then, with going further and further within alignment, business and IT have to develop together the strategic plans. So IT should be part of the group developing the business planning, but of course the business must have a strong part in developing the IT strategic planning. And what's also very important, it's the point, steering committees, what you need as a formal decision-making process within the steering committee, where as well the IT as well the business part is represented. Then the next group of criteria for alignment within that model, it's about partnerships, and that's more about how IT and business is working together. It's not so much about what they are doing, but how they are working together. And here the message is that they should work together. So all projects, all programs should be shared. That means shared risks and shared success. So if it's a success, it should be success for IT and for the business. And if it's a failure, it should be a failure for both. So both should be committed for success. I mentioned here one question. If you are thinking about outsourcing, of course, alignment is not the opposite of outsourcing, but if you're thinking about outsourcing, you have to consider that. Because the relationship, the partnership with an external partner, sometimes it's a bit different from if it's an internal IT provider. Okay, then the next group of criteria, it's about scope and architecture, so how your IT environment is built. And here it's important to think about architecture that is able to really support the business, to be flexible enough for changes within the business environment, and to be able to deliver also new emerging technologies if needed by the business. And again, this should be developed together from the business and from the IT. That's the key message, in fact, doing it together, aligning things. And then the last group of criteria within that alignment model, it's about skills, so it's about people. And here it's about education, also doing education and training together, business and IT. For example, one thing we did when we started implementing our new electronic patient record, the colleagues which were responsible for training and coaching and help desk, before we started the program, they were a few weeks with the nurses, with the doctors, to just follow them a few weeks, different specialisms and so on, to get an idea how they are really working it. And not to approach it too much from the IT side, but to approach it from the side of the end users. That's very important. Okay, here just an example once more about skills, level 5. If you want to reach level 5 within that maturity model, what does the model say? For the skills, for example, innovation and entrepreneurship should be the norm, the standard within your organization. Education and cross-training, your combined training from business people and IT people should be available across the enterprise and so on and so on. So it's fully integrated. Okay, then here, so here once more we have within the model, IT alignment is grouped in 6 groups of criteria. Then the next step within the model is to assign a maturity level to each of the criteria and sub-criteria. That's how it works. And the 5 levels, they start with a top process, so you just know about alignment, but you're not very far within the process. Goes from a committed process to a focused process, and at the end to optimized process. That's the level 5 end result. Now I'll give a few more explanations about that. So for the level 1, it's the lowest level within the model. And if we see here an example for communication, what does it mean? It does mean knowledge sharing. It's not integrated within your processes. It's sometimes ad hoc, for example. Understanding of business by the IT, it's a minimum, and the other way around, it's the same, it's a minimum, and so on. So it's very basic kind of alignment. Then the next level, level 2, it's called the committed process. In fact, it means that you understood what alignment is, but you are just setting the first steps in that process on that road to the higher levels. And so, for example, if we take a look at the criteria from the group measurements about IT metrics, it means it's not really still the technical measurements, for example, the number of text messages, but it's more about the costs. What does IT cost? What's the cost of your IT department? Then, level 3, it's established in a focused process. That means IT is becoming more and more a part of the business processes. If you are doing business planning, you're thinking of IT, IT is involved, and as a part of the overall process. Then within level 4, IT is seen now as a value center, a value generating center. And if you take a look at the common communication group once more, so the characteristics, for example, are understanding of IT by the business means here the business is very good aware of the potential of IT, that they really know IT can help the business. Knowledge sharing, it's institutionalized, it's a standard within the organization, and so on. Then the highest level, it's the optimized process, an optimally aligned strategic alignment maturity. And if we take a look at governance, for example, the business planning is done from IT and business together, and it's extended also to external partners, for example, in our case, a hospital to the patients, to the external providers, the local doctors, government institutions, and so forth. If you take a look at internal, the steering committee, for example, it means that IT and business are working in a partnership together within the steering committee and are deciding together which direction to go. So what you see on the left side, this level 5, it's really the high end, the optimal process, and statistics show that about 80% of all businesses are level 1 or 2, or just maybe close to 3, but are lower than level 3. I don't have any numbers for hospitals, but I think it's not so different, what I can say from my experience. Okay, here once more about the 5 levels of alignment. We see in the beginning there's a big gap between the business and the IT strategy, and it's going further and further within your alignment model. IT and the business, they are more and more integrated. The gap is closing. Okay, up to now, we've seen the 6 criteria from the model. We have seen the maturity model with the 5 levels of alignment. And now I would tell you how you can use that to start in self-assessment, for example, to see how far your hospital or your business is already within the model.
Could you summarize that? 2 minutes left.
Okay. Okay. How you can use it as a self-assessment? You can use the Delphi method. I don't know if it's known already, how it's working. So you're working with a group of about 10 people, 8, 10, 12, from business and from IT. Maybe a bit more business people, that would be perfect. And each one is doing individual evaluation of all the criteria groups and the sub-criteria groups, assigning a number from 1 to 5. Then you're coming together and you are discussing the results within the group. And you can focus on the extreme values. For example, if someone for understanding of IT from the business gave a 1 and the other one 5, then you should explain them why they did it. And after that discussion, you do a second evaluation, once more in group then, and then you use the average of the sub-criteria of one group to get the maturity level of that criteria group. And you do the same thing for all the 6 groups, and then you have your maturity model. So just to say what are the real benefits of that model, it's not so much that you get a number of your level 2 or 3 or so, but it helps you to start the process, in fact. So you're doing that with people from IT and from the business together. You start discussing alignment, you see the weak points, you can see the strong points, and it sets you on the road for alignment. So that's the general idea about it. So due to the limited time, I will stop here, I think. If there are any further questions, it's now the opportunity.
Yeah. Questions, comments? Yep, okay, so I would have a general question. How can IHE help you in those processes? I'm not sure that I got that point to a certain extent.
I think in the first step, it's not about integration and connecting systems, so there's not a very strong role for IHE. In the first step, it's about defining what the business requires from IT, what it wants from IT. And if, for example, it's a business strategy to work together with external partners or to do a merger or whatever, then you have to look for the concrete, for the specific IT tools to do that. But that's the second step. So in the first step, it's not about technical things, it's just to define what we want to achieve together, IT and the business.
Any other questions or comments? Yep.
I think what we see today is that we are a little bit decoupled. We have it's detached. On one side, we invite the users group into the IHE world, and the user groups, they are normally defining the right use cases, and then they hand it over to the IT group and so on. It's a similar process what you have described, but it's completely detached, because you have done this by your own, this experiment, or the experience is based on that. And I think that is what we must achieve in the future. Bring all the parties together, all the stakeholders, because it's good that you have this experience now, because it's much more easier now to align yourself. Let's assume that we come together. But I'm pretty sure that you can spare time and money, because this is, if you join the users groups, then I'm pretty sure you will find many things that are considered in the IHE framework.
Okay, thank you very much.
Thank you. That was exactly the point I wanted to state, that you have to bring together all the different parts of hospital, business, IT, and it's important to stay together. It's not a one-time shot, it's a process, long-time process.
Hi, Derek Ritz. I have to admit something before I start my question. I worked for a couple of decades in supply chain management before I started working in healthcare 7 years ago. And I've been trying to find a way to express what it is that I'm seeing as a disconnect, and I think that I've got it. So one of the things we've been talking about a little bit is optimization. And one of the truths of if you're going to have an optimization discussion is you have to say optimal with respect to what. And in both of the presentations, I believe that we've been talking about optimal with respect to revenue generation or efficiency of the businesses that we've been hearing about. And one of the things that I've come to realize, I don't know when it happened, but I'm sure my father would be spinning in his grave to know that I've become a socialist, and I don't know how. But I think if you were talking about optimal with respect to the production of health, that's when the interoperability becomes important, because sharing information about a patient helps optimize that patient's experience when they're receiving care, helps optimize the ability to deliver care to that patient. And in neither of the presentations were we talking about how we would optimize patient care delivery, although it has to be, one would think, one of the things that would be the definition of your business. And in what way does that change what the role might be for IHE, since it is about sharing of information and about interoperability? And I think that's sort of the thing that I've been finding as a disconnect. Optimization with regard to financial performance might be different than optimization with regard to safe patient care. Okay, any other comments?
I had a bit of an epiphany during the presentation as well, because people ask, what is it that people like myself do about my health in addition? So, what I've got from a clinical background, who's had been involved in IT over a number of decades, and so standards and so on. And what we're really doing is exactly what you've been talking about, is in fact alignment of business and IT. That's our job, is to support business, to give business the skills to be able to do the alignment. But I think that's where there often is a mismatch. I don't know if your hospital or hospitals in Europe, but a number of hospitals in Australia that have a medical informatics department have people dedicated or trained and skilled with their enough IT knowledge and business or clinical knowledge to be able to interact and to engage. Very few hospitals have even people like that in Australia. The concept of a CMIO and a GP is almost unknown. And so I'd be interested to know in your hospital how you actually engage with the business and what resources and skills do you think business needs to be able to actually work effectively with the IT side to achieve that one.
Okay, thank you very much. Maybe we can discuss this in the next round. So Alex, I would like to proceed.
I would like to proceed to the next presentation, which is going to be given by Alexander Schaller. Sorry for rushing you. He will present on he's actually one of the IHE co-chairs in Austria, and he's going to present on the interoperability aspects and work which he's done in the area of lower.
Thank you, Björn. Thank you, Björn. Good morning, ladies and gentlemen. Now I will give you a contrast program to the both presentation before. I will talk about a strategy. The IT strategy is a completely aligned IHE strategy, and I will talk you something about the difference between theoretical aspects and the practical experience in Lower Austria. As you can see, a lot of houses, these are 27 hospitals in the federal state of Lower Austria. Nowadays they are in the ownership of the federal government of Lower Austria, but when I started to integrate all the systems, they were in the ownership of 22 different cities in the country, and therefore they all have different IT systems in different levels. And my task was in 2003 to connect all these hospitals together, to share information. My idea was to share, to go up from the old-fashioned model, from the push model. You have to ask another hospital, do you have some data from a patient? Please could you send me? If somebody is at home, you can get the data. If nobody is at home, you have no data about the patient. Therefore, my decision was building up a shared infrastructure for the whole country. Now I will show you some geographic aspects. Lower Austria is the country surrounding Vienna. You see the white dot in the middle, that's the capital of Austria, Vienna, and the yellow dots are the hospitals distributed in Lower Austria. We have subdivided in some areas called Waldviertel, it's the Wohnquarter, called Weinviertel, it's the Weinquarter, and so on. And in each of these quarters, we have 5 quarters. It's a little bit different. And in each of these local area, we have one large hospital, and the other one are some smaller ones. The number of the beds at all is about 8,000 beds covering, and the largest hospital covers 1,000 beds. We have some more other hospitals are from the range from 200 beds up to the 1,000 beds. Now, when I started in 2003, the first step was the decision to build up a sharing infrastructure. The next decision by my side was I have to use international standards because we are thinking about communicate with other countries in Austria, but we thought also about to have some communication with neighboring countries. For example, there's a cooperation in the north with the hospital Gmünd, with the Czech Republic, and therefore it was clear for me to use only international standards. It's not useful to build up your own standards for the country. And the second step was I got a decision from the federal government in Lower Austria using only international standards and renamed the standards DICOM, HL7 and IHE. With this starting point, I started to run a tender to get the systems. And all this experience building up brought me 3 years later to the National Health Record Project. I was the project manager for 3 years there, and I brought in the experience in Lower Austria. I brought in the architecture in the National HELG, as Hubert Eisen mentioned yesterday. It's based on a XDS environment. And during this period on the national level, we got the decision 2007 for a recommendation to using IHE in Austria, and we got at the end of 2008 the decision for using IHE as a must for all healthcare projects. Now I will come back to the situation in Lower Austria and will give you some numbers. Here you can see the numbers of last year. We have about 380,000 inpatient treatments applied on 270,000 different patients. We have a lot of more outpatient treatments, about 2.8 million outpatient treatments on about 1.2 million patients. And we have about 15,000 employees in our hospitals in Lower Austria. And now I will see you some numbers, maybe you are wondering about them. These are the numbers of using nowadays our XDS environment. You can see it is a long way from starting 2003, beginning to using this infrastructure, and later on I will explain you the reasons why it takes a long time to use such a systems. You can look at 2011. You see 1.1 million patients was in the system, in the patient index systems. And we had inside the system 3.2 million, and we had only 354 accesses each month. You will think about a lot of money for such low accesses. 1 year later, we had more patients, about 1.4 million. We have already 5.1 million reports in the system, in the XDS environment, and used 2,300 times a month. And now you can see 1 year later, at the beginning of this year, we have 1.6 million patients in the system. It covers nowadays all the citizen inhabitants of Lower Austria. We have 1.7 million reports. Nowadays we have already 850,000 DICOM studies, and now we have each month 13,000, approximately 14,000 accesses each month. Now I will finish this presentation and I will give you an idea how to accelerate and how to implement and how to educate the people. As I mentioned, it was necessary to build up this XSI infrastructure. And when I started the tender in the year 2004, we started with the implementation in 2005. The system was technically available at the end of 2007. From this point on, we could use the systems, but unfortunately, it was not very comfortable integrated in the real existing systems. If you would have access to images, you have to use a parallel portal to the usually used IHE system, PAC system, RIS system, and therefore we started to really integrate the document consumer, the document source in all the existing systems, or we changed some systems with new systems, and therefore we are asking in tenders and procurement processing this document consumer, imaging document consumer has to be inside the systems, so you have not to change, and this is the reason why we have now a very sufficient usage of the systems. Now I will come back some other issues implementing the system. When I started the system, my requirements were we have to separate between document source, a separation between document repository and document consumer. And we have to do a separation between the application infrastructure data. In this case, we are always the owner of the data. In other cases, the owner of the data is sometimes the provider of the infrastructure. And nowadays, when we buy new systems, I have a lot of requirements of IHE, and most of them are must. This is the experiences. Now it's going on, and we have enough companies, we have enough competition to require these things as a must, and it works nowadays very well. All the new systems, for example, we are purchasing now a system for the largest hospital, and it is a must to integrate in the PAC system the document consumer, imaging document source and imaging document consumer. And we have enough competition for these companies. And that's the only way to go forward. One experience was we have 1.5 years ago, I had a procurement process in the hospital for a PAC system, and we gave in some musts, and we are very we was unfortunately a little bit too more flexible, and we say it's necessary to provide these profiles at latest time 1 year after beginning of the installation. We installed the systems, and after 1 year the provider told us it's a pity. We cannot deliver it. And with the now procurement, the requirements were a lot higher. We gave in 50% of the IHE profiles have already been integrated in the systems, and they have already been tested on collectathons or other similar situation. And we lost in this way some vendors. They promised us they will do it, but with this improvement of collectathon, we are on the secure side to implementing new systems. I think it was a very pragmatic way to come up from very different systems. And it was no way for us to change all the systems in the different hospitals in a big bang situation. So the decision was the right one to integrate already existing system and step by step to replace it by newer systems. This include integrated IHE document consumer, document source environment. So I think it was a fast overview, and I'm ready for questions.
Thank you very much, Alex, for this very comprehensive and interesting presentation. Questions, comments? I still recall that there was something somewhere in the back, which I cut off by half an hour earlier. So please, go ahead. There's one over there.
Can I just clarify? You said that 50% of the systems have implemented the IHE profiles, or implemented 50% of the IHE profiles?
No, it is the requirement at the beginning when they gave us an offer to us. They have already to have 50% of the profiles covered in their product, and they have to test it on a connector top. The rest of the other 50%. They have to add in the next year.
Promise me you don't let me be the last question. So I'm Mike Mismont from Canada. So I listened to what you're saying, Alexander, and I just want to have that story told in Canada. You covered a few areas that are really important. One is the mandatory expectation that your vendor community will come to the table with IHE built in. That's an issue in Canada. There's a fear for making those mandatory requirements because the fear says that the vendors won't have that, so they'll have no vendors. And it's a chicken and egg situation, and you've incented the process forward. And now everybody's catching up, and I think that's a great story. What I need is for you to document your success as part of IHE's success story, so that I can take that to Canada and say, look what Austria has done, look what Lower Austria has done to help facilitate the exact same problem that we're trying to solve in many places in my country. So somehow we need to harness this success, and I again would urge you to connect with Chris Carr and find out where the URL is for you to just exactly document what you said today, and so that it can be shared with the rest of the other deployment teams.
I have metrics for the requirements of different products, and we have established a working group in IHE Austria for procurement, and a lot of people are working together to find the requirements to follow the maturity of IHE compatible products. Sometimes it's a pity. We have a lot of IHE profiles available. We have a lot of tests on connector dots, but unfortunately in some areas we have no available products or real implemented systems. And it works very well in the IPI infrastructure, it works very well in the radiological area, it works quite well in the laboratory area, but in other areas it's no way to require it as a must. For example, we had a procurement process for implantable cardiac devices. I took a look at the results of Connectathon. I was very happy. All the companies offering the product to us had participated in the Connectathon process. And then I asked the salespeople, have you already implemented that in your products? What is IHE? The salespeople didn't have any idea about IHE. And so we could not require it. One of the experiences, you can only require such profiles if it's possible to require as a must. If you require it, it's nice to have. It is one of about 2,000 parameters, nice to have, and so you cannot distinguish with this connectivity. And it's a very difficult work to find which masts are the right one.
Yeah, I mean, this is, I'm sorry, Chris. Just a short comment. I fully agree with what both of you said. Actually, we're trying, because I'm also responsible for procurement in our hospital, in our region. We usually try to do it that way, that we say we don't exclude non-compatible vendors, but we simply say if they are compatible or compliant, then just win. That's pretty simple, and the way we manage it. So if there's 10 which don't have XDS support, and one with the XDS support is the one who's going to win immediately. That's the easiest way to. So we just have procurement criteria in a way. That is at least something which helps you in the first run. And usually, to be frank, what we usually do is we go with the tenders, and then we finally open the tenders, so that we can also negotiate and do the stuff free. That's a possibility which we have in Germany. But first, perhaps Chris, and then, or I don't know, yeah. Then you might be able to answer this question directly.
I would, sorry, Chris Carr from IHE and RSNA. I would echo what Mike said, Alexander, about wanting to promote and document the successes that we've had in the world. But more general questions to the group, to the panel. I guess, to Alexander, was there a mandate that you were replying to in implementing IHE, a mandate to communicate or share information across institutions, across care sites? So that's the first part of the question for you to answer. And then for everyone, was there any attempt in your analysis of business processes to put a value on interoperability on using standards to, to achieve interoperability? Is there any attempt to kind of place a business value on that within your kind of decision-making matrices?
Yes, it was a mandate for sharing information, and at the starting point, we thought as well connect all the hospitals as well, general practitioner. But on the other hand, the general practitioner are not willing to participate in such a model of collaboration, because I think it's disturbing their business model, hiding the information and have some customer relation to the patients. And therefore, connecting the general practitioner will be postponed to the national health record. You heard it yesterday from Hubert Eisel. It will start at July of 2016, and then we can integrate it in this way based on the national law.
There's one question in the back. And then I would perhaps also like to come back to your point about the information model aspects, because I found quite interesting, and I'm not sure how to understand it correctly. Yeah, please.
Edward, Austria. Alexander, you just forgot to mention that already about 1,000 GPs in all Austria are receiving discharge letters from the hospital, but not using IHE. So they are receiving about, I think, 2 million documents at the moment. And but they only receive, they do not send data into the hospital system. So this is also reality in Austria, and we are proceeding in direction of IHE also in the GP markets. Yeah.
I think if we forget the physicians and the infrastructure for transmitting reports, but it is a pushed model, and here we have the sharing information, the pull model, and if nobody is at home, nobody can send me a report, and that's the main problem. The people coming the weekend in the hospital, if they are ill, and you cannot call a general practitioner during the night, you cannot call a general practitioner the weekend, please send me the report of this patient. And therefore it's necessary to switch from the old-fashioned point-to-point communication to the new model of the shared information.
It would be very useful in our domain, and I imagine in other domains, to know which vendors have products actually in the marketplace that support IHE profiles. I'm just wondering whether it may be possible to ask vendors at the time of passing the connect block to give a list of which products they actually support in addition to the employment domains, so that information can be distributed. It would then be possible to promote those products locally.
You mean like a conformance statement in a way, or for the product? Or?
Which products?
Yeah, which actually products?
Well, which is the initial conformance statement for context.
Yeah, can I come to that? Just two resources that are vital from that query. And the first one is the net result matrix, which just matches integration providers and actors and vendors. So that is easy because people connect to all help connected already. So that is. But the other one is the product registry, which is an additional step, which also takes into account the integration state, which matches it. The integration provides access to two products in their own declaration of vendor. So that is the step probably that we were referring to, because any further step will require there is no any provision for any additional steps and discussing that.
The bit that is missing is which markets they actually market those products in, because actually finding out, as we heard, whether a particular company markets an IHE supported product in your marketplace.
I guess that even the vendors sometimes do not know that.
It would be great to ask them.
Okay, further comments or questions? If not, I would like to give you the word again, because what I didn't fully understand, I mean, working on the information model gives usually an abstract situation. Then you have to somehow drill this down into your operations and in the techniques and in the user's sphere in a way. How did you do that? Maybe somehow I didn't get that because it sounded so easy, but okay, so it was not that easy. But could you give some more background information on how you did that?
Okay, prior to when we installed our information domain, actually, the infrastructure for the information domain, we had like 9 various ways of defining the personal ID. And we are basing everything out of DICOM. And in DICOM you have type 1, 2, and 3. 1 is mandatory and it needs to be filled in. But that is not a suitable standard. Take the comparison for the electricity with the standard of that one. You just say it's a 5-figure volts. The computer will explode. But we know for sure it should be somewhere around 230 to 40 volt or in US 110 or something. But the transformers, they actually apply to that one. So what we did, we actually added type 0. The patient ID should be there. It should look like this. And now in Sweden we have the opportunity or the possibility to have a national issue of personal ID. So we could actually control if it's a correct personal ID. But you need to define that, because if you don't have that, you cannot have an interoperability on a business level. You can have it on a technical level, because we can interchange information. But the value for me as a radiologist, I'm not sure which patient I'm looking at. And I could have a various sort of like 5 posts, and it's the same patient. And by doing that, we could hand it over that spec to the vendors. And now they know for sure that that's an important part. And what we see within the radiology domain, we actually define just 5 issues that are very important to do the functional interoperability. Personal ID, the name, the correction of the reason for having a radiology procedure, the issuer of the radiology procedure, and also who is responsible for referring the procedure. Now we could do a totally system-independent radiology enterprise by doing that one, because that is not something that our vendors know by heart. They know for sure. We have a patient ID, and it's a fee. Just fill it in, and everything is fine from our point of view. We populate their database and stuff like that. But when we want to do the migration, when we want to do interoperability, do we convert that into XDS? What should we look for? We know for sure, because it's also patient safety issues as well, because me as a referring physician, I could do a query and see a regional overview, but am I sure that I see everything that is produced? I'm not sure if we don't do the correct query possibility, and we do it by patient ID, as we have the opportunity of doing it. But I need to feel secure when I do the query, I see everything, because then I can do my judgment on what I want to include in my report or not. And if I do the report and there should be something there, but with the wrong ID or something, it's my mistake because I signed the report. So that, but it was not easy. It took us 2 years to do that within the radiology domain actually. But after that one, we could have a much greater dialogue with our vendors, because now they understood our standard issues. They could take that information model, tweak it into their technical standard issues in Dimension 7 and also in IHE. So that's what we are running right now. And now we have, like, in our radiology domain, we have like 800 million diagnostics. Now we want to tweak that into XDS. And we see issues there. Should we do it in one repository, 2 repositories? How do we do the migration, the status update? But it's much more easier now when we define the information model. So that was my comment.
I think I got the point. Thanks very much. Okay, sorry, but I would like to come to conclusions. We can perhaps do that in the break then, because it's 11 now. Thank you very much, everybody. For me, it was a very interesting session. What I learned on one side, that again, as always, it's useful and helpful to listen to the users and to understand their needs and understand what is their concerns. The second element, that if we want to be heard and helped by them, we have to offer concrete things, so it cannot be too blurry, because otherwise nobody's going to accept it, nobody's going to understand it, and it's not going to be really helpful. Obviously, there are differences between the countries and situations and all that, but still there's a common need. So I fully would support that, and I think there's an urgent need to get closer to the users. Sometimes, as we all know, also users are underrepresented to a certain extent in our community, the standardization community. So finally, we've had a very good example from Lower Austria about how you can do it if you apply to standards, and that you can solve it. So it was a positive example in that way. So I would like to thank you really for your attention, and then the break now is half an hour. That's great. Okay? Thank you very much.